Okay, so without further ado, I'm going to start my talk. And so I start this talk with a quote from Mother Teresa. I know God will not give me anything I can't handle. I just wish God didn't trust me so much. And I'm willing to bet there are people in this room that can really relate to that sentiment. And so that's why I start with that, because you're not alone if you feel that way. So persistent pain, formerly called chronic pain, it's for whatever reason now called persistent pain. It affects approximately 100 million people in the US and costs $500 billion annually. And so it's a huge problem. And there are different types of persistent pain. It can be neuropathic versus nociceptive. And I'm trying to figure out the microphone and get it right here because I feel like I'm getting some feedback. So just tell me if I'm too close. But what we know, neuropathic pain is pain that arrives from the nervous system, so damage to the peripheral nerves or to the spinal cord or to the brain. And then nociceptive pain is more that muscle pain, skeletal pain, not directly related to nerve damage. But we know that neuropathic pain is less responsive to treatments and is associated with worse health outcomes, and it's where we're really going to be targeting our discussion today, though we will touch on the other type of pain as well. And so there are types of pain. We have primary pain. When we're talking about transverse myelitis or diseases of the central nervous system, it's a direct consequence of injury. So you see that spinal cord there, that MRI, and that gray spinal cord, in the middle of it is a white lesion that goes down pretty much a large component of that spinal cord. That's the damage, and that pain is directly a result of that damage. But you also experience secondary pain, wear and tear of the joints, for example, and we'll talk about that more, as well as tertiary, kind of how you perceive pain and how you cope with it and how it affects you emotionally and socially. But going back to primary pain, so we have neuropathic and spastic are the types that originate from damage to the nerves. So neuropathic pain is inappropriate, painful presence of burning, electrical sensation, tingling of the arms, face, really anywhere in the body. I'm willing to bet that a lot of you who have had TM know exactly what I'm talking about, and I don't really need to define it for you. And then there's also the spastic pain, the involuntary contraction of the muscles that can be painful. Sometimes it's not painful, but we're going to concentrate most of our efforts on the neuropathic aspect of pain. It's in surveys and studies, it seems to be the one that most affects people's lives and the one that is more constant and interfering with their ability to engage in what they need to be doing every day. So neuropathic pain, we've already talked about what it is, but it's also worth noting that it's a persistent pain, and really, as we talked about, it's not well responsive to treatments. But you've heard the description of burning, shooting, tingling, but then there's also other types of neuropathic pain, including Lhermitte's syndrome, which when you've had any inflammation in the spinal cord, if you bend your neck forward and you get a shooting electrical pain down your spine, that's called Lhermitte's. And then banding pain that really corresponds to your lesion location, where you get just this tight, girdling, pressing sensation around that area. And then allodynia, so that's when you perceive normal touch as something excruciating. So for the example I use, if you're touched with a feather and it feels like you're on fire, and if you can, for those of you who don't experience that, if you can imagine that, just having bed sheets on you, it would really impact your ability to sleep, for example. So what causes it? Well, we're all here for probably one of these reasons, right? So multiple sclerosis, transverse myelitis, neuromyelitis optica, stroke, and spinal cord injury. And it's worth noting for the people in here that have ADEM that there is some component of transverse myelitis, often with ADEM. So you are sensing about 1 million impulses all the time that are then perceived in your peripheral nerves, go up through your spinal cord and are interpreted by the brain, right? So when you have damage to the spinal cord, your brain tries to fill in missing data, and oftentimes it ends up feeling like pain to you. So rather than just knowing exactly what it's trying to experience through touch, it interprets it incorrectly, and you feel exactly how you all feel with the burning and shooting pains. And so you can have nerve damage to the peripheral nerves. That's the most common, actually. Usually diabetic neuropathy, chemotherapy-induced neuropathy, those types of things are your peripheral nerves that are damaged. But most of the diseases we're talking about today, it's your central nervous system that's affected, often your spinal cord. And there is evidence to suggest that's the worst of the worst kind of pain. So neuropathic pain is worse than other pains. Central neuropathic pain is the worst of them all. And then what does it cause? Well, there's evidence, a lot of it's not in transverse myelitis specifically, a lot of it's in either spinal cord injury, multiple sclerosis, or neuromyelitis optica. But in those other conditions, which same thing, you have damage to your spinal cord, there's increased depression, less enjoyment of life, difficulty with ambulation, with sleep, and decreased social engagement. So, the prevalence in multiple sclerosis of neuropathic pain is 29 to 86%, but it's also been shown that those who have lesions in their spinal cord in the setting of MS tend to have worse pain than those who do not. And then in NMO, it's even more than that. 62 to 91% of patients with NMO have neuropathic pain. It typically presents weeks to months after the damage has occurred, which is an important component that we'll talk about in a little bit. It can be self-limiting or sustained, so some people, as their spinal cord is healing, they experience pain, and after several months that pain goes away. Some people it takes years, some people it takes a lifetime, unfortunately. And we already talked about how it does affect quality of life, but it can be worsened by metabolic stressors. And what do I mean by that? So a lot of times, like I said, the pain is oftentimes delayed. Earlier on, when you present with new neurologic symptoms attributable to your spinal cord, more often you have loss of sensation. And then as the healing begins, you begin to develop these hyper sensations, these painful sensations. And so that's about the time period where people will call myself or Dr. Levy or Dr. Pardo and say, I think I'm having a relapse. Because all you know is your body is experiencing something that you hadn't been experiencing days or weeks before when you had been having this acute event. And more often than not, it's not a relapse. It's as the healing is happening in your spinal cord, and as that information is being filled in from the damage of the spinal cord, again, you experience it as pain. So a lot of things can cause this episodic worsening of your pain. And it's usually some kind of metabolic stressor. A lot of times it's temperature related. So if it's a sunny day, I'm from Baltimore, if it's a sunny day in Baltimore and you're outside and it's 95 degrees, then you'll feel a re-experiencing of old symptoms. So increased pain, increased weakness, increased fatigue, to name a few things. And then in the setting of fever and infection, I would say that's probably the most common worsening of pain that we see. It's not as common as just the ambient temperature, but it tends to cause more dramatic effect. But even just stress. So we know women surrounding their menstrual cycle have increase in symptoms because of the hormones are such that they increase your body temperature. And then medication changes. We've had quite a few patients who we start on a medication to treat their pain or some other symptom, and it actually worsens their pain acutely because as we're titrating, as we're going up on the medication, it causes a metabolic stressor to your body. But usually, or always, that should subside. So you should go back to whatever your new baseline is as that thing is removed. So as your temperature comes down, as your infection resolves, all those types of things, then you go back to how you had been. But depending on how frequent your pain is, we don't want you just being in pain intermittently, right? So we want to talk about ways to treat your pain. But the important key component is it's not indicative of worsening of your disease. There's no new neurologic damage happening. There's no inflammatory reaction that's causing it. So the medications for pain, I thought this was going to do this on its own, but apparently I'm not very savvy with the PowerPoint. So the point is that there are as many medications as there are doctors prescribing them. And different people, in my experience, having worked with more than one doctor in this type of setting, is that different doctors have their preferences and they're very, very sure that it's the best one. But in my experience, it's much more dependent on the patient. Different patients are differently responsive to different medications. And that's really frustrating because you go home on gabapentin and you're hoping that your pain is going to be made better, because for some reason that's the one everybody starts with, gabapentin. And sometimes it works for people. Sometimes it works amazingly well for people. And sometimes it doesn't. But the other part of it is we have to titrate up on these. Oh, look, I missed one. But the process of finding the right regimen for you is infinitely frustrating. And it's frustrating during a time that you're in pain. And so oftentimes, I just encourage you to try and stick with it while we find the right regimen for you. And the reason for that is we often start off at a low dose and work our way up. And the rationale for that is, A, we don't want to give you more medication than you need because these medications cause side effects, fatigue being a big one, and you have lots of reasons to be fatigued. B, so when you're on these medications, you'll either have side effects at a certain dose and you have to be taken off of that medication, or you'll reach the maximum dose and not have the effect that you want, the positive effects, or ideally, obviously, the situation would be that we find the right dose for you that's actually treating your pain. But getting to that process and assuming that the first one we've tried is the correct one that helps you means that there's a lot of waiting and pain involved. And so we often will bring in other pain medications and start with different classes. So most of the medications we use that you saw on that previous table are anti-epileptics, antidepressants, and my brain just went dead. But those are the two main ones, and then sometimes some anti-inflammatory medications. So oftentimes when you're pain-free for 3 to 6 months, they might do a trial where they go down on medication to see if we got you through that period and that your pain is going to be gone, that you've done enough healing. And then if that's not the case, obviously we just go back up on the medication. But the good news is medications are not the only way to attack pain treatment. So it can make you feel really out of control that you're waiting for these medications to work. And I will caution you to be patient, try these medications, try them methodically the way that they're supposed to be tried. And the reason for that is you almost never go back to a medication. So if you go, oh, I threw in the towel on amitriptyline, it didn't work for me, then most of the time, most doctors and practitioners aren't going to go back to amitriptyline. And that's potentially one that would have worked had you stuck with it to the proper doses that actually treat your pain. So we will talk about the alternative options, but first I want to talk about cannabis because this tends to be a hot topic. And as I've done more and more of these types of patient days, I've found a lot more and more patients are trying this. And so the joke on here, you might not be able to read it. I don't even know if I can read it from here, but the doctor says, yeah, I'm not sure I can. Your lab work came back, and there's really no easy way to say this. You're just too healthy for medical marijuana. Well, so the reality is that this is becoming more of a hot topic in the U.S. We have, oh my gosh, I really can't see this. We have all the blue states where it's openly legal to use cannabis, and then the green ones where there's medical marijuana available, and then the gray ones that it's not yet available. But the trick is, so in Maryland, for example, we passed a law 3.5 years ago to legalize it, and the program's still not up and running. And that's because there are actually a lot of logistical issues with cannabis programs and with just use of cannabis in general. But here's what we do know. It has been shown to be beneficial in other autoimmune diseases of the central nervous system, for pain treatment specifically. We know that the endocannabinoid system plays an important role in neuronal circuitry. Preclinical studies support the analgesic effect, the kind of dulling of pain effect of cannabis. And then there's additional antidepressant effects, which we'll talk about a little bit more, but we do know that depression can worsen pain, pain can worsen depression. But the issues include several things, including the method of delivery and quality control. So depending on where the plant is being grown, how it's being picked, where it's being stored, what formulation it's being dispensed in, all those things affect the amount of endocannabinoids or the cannabinoids that you're receiving. And then there are contaminants to cannabis. So they've done studies to show that not a small amount are infected with fungus and bacteria, which is obviously not something that we want you exposed to. And of course, the growers usually are not doctors, they're not pharmacologists, they're growers of cannabis. So, and then there can be some symptoms that are associated with it, including some that affect your heart rate fluctuations and blood pressure fluctuations. And then euphoria, anxiety, and decreased ability to think can occur, particularly with the THC part of the cannabis. So part of what we want to do as a pharmacologic medical community is figure out ways to get the good parts of the cannabinoid effect without the bad parts of the THC effect. Some wouldn't say so bad, but similar amount of harmful cancer-forming compounds as cigarette smoke. So ingesting it, smoking it, can affect your lungs and your lung function. So now we're going to talk about secondary pain, and that's the musculoskeletal pain. Usually, so misuse, disuse, overuse, or abuse. When I talk about misuse, oftentimes patients, your body is made to walk in a very specific way, and your body mechanics are such that it doesn't want for you to walk in a different way. So when you've had some kind of injury that affects your ability to walk the way you always traditionally used to walk, it puts a lot of wear and tear on areas that where it was once easy to walk from here to the door. Now you're having to think about it more, you're using a lot more energy, and you're stressing out those joints by just tweaking your body mechanics even just a little bit. And then disuse. A lot of people tend to withdraw from activity when they're not able to participate in activities the way they once did. And if you use it, you lose it. It's very true, that old adage. So if you're not engaged in activities in the same way, your bones lose a lot of the mineral hardness to them, and so you can develop fractures and all sorts of bad things. Muscle atrophy, things like that. And gosh, I have all these cartoons that I can't read from here. But so secondary management, the way to deal with that is first to prevent it. So if we can get you to get into physical therapy early, before you develop bad habits with your new way of walking, that's one of the best ways to really challenge you to not develop structural issues, body mechanic issues. And so we love our colleagues in physical therapy. I can't say enough about them, and I'm going to go over some of these things, but you have much wiser, smarter people who actually have much better, stronger education in this that are going to be talking to you over the next 2 days, so I won't belabor the point. But in that cartoon, you have some caveman who's pushing a cart using square wheels and not getting very far, and somebody behind him tries to offer him a wheel, and they're like, no, we've got it. And that's what it's like when you don't utilize things like aids and AFOs and braces and walkers and all these kinds of things. You're making it harder on yourself ultimately, because like I said, you're going to cause these other structural damages and stressors to your joints. And so it's really important to get in with physical therapy. And then heat and ice therapy can go either way. Some people say one, some people say another. I put a poll out on a Facebook group, and literally as many people who said heat helps them as the same number said that cold helps them. So, but we do encourage just trying different things, trying different modalities to attack your pain, and seeing what works for you, because unfortunately, much of this stuff hasn't been well researched, and even when it has been well researched, it's conflicting, and even when it's not conflicting, there may be some people it helps for, even if not the majority. Medications, like we've talked about, and specifically for the inflammation in the joints, some of the anti-inflammatories, just like ibuprofen, can be very helpful, but that can be hard on your stomach, so I don't suggest you do that without everybody on your medical team knowing. Aqua therapy, massage, yoga, lots of stretching-based, activity-based methods for getting around and moving are really important for everybody, but in particular those who have had any kind of weakness or structural problems in their spinal cord that affect their ability to move freely. And then tertiary pain. I'm full of the cartoons, aren't I? So there's a guy in the mouth of an alligator, and the doctor's asking, so can you rate your pain from 0 to 10, please? We definitely like things to be very numeric, don't we? But the tertiary pain, things like the social effects. So your experience with pain previously affects how you interpret pain now. And then differences in cultural and gender ways of being also affect how you interpret pain. Difficulty quantifying pain to others. So sometimes you may be one of these people who has recovered your motor function quite well, and to your next door neighbor, you look like you ought to be functionally just fine, and yet you're experiencing pain. And it's hard for people to really understand that, to really be as compassionate about it as they ought to be because of just really a lack of awareness. And then availability of social support. So the more people you have surrounding you who understand what you're experiencing, who maybe have seen your journey, that can oftentimes help with how you cope with pain, which in turn helps with your interpretation of pain. And then the emotional component. So pain, we know, can produce anxiety and depression and stress and sadness. And then the psychiatric comorbidities are very common, just like we've talked about, and actually we'll talk about a little bit more. So I said there were things you could do to influence your pain, and I haven't gotten much into them until now. But we did talk about physical therapy. Not just physical therapy, though, but just moving around, doing something active all the time for a lot of the reasons we discussed, to prevent disuse and to prevent improper use of your muscles and joints. So when you have pain, you tend to move less. When you move less, you tend to increase your disability, and when you increase your disability, you tend to increase your pain, and so it's one of several vicious cycles you're going to see in this presentation. But we know that participating in exercise helps our body, helps our mind. That's nothing new to you all. But we know that also that motivation plays a large role in whether we follow through with a regimen. So for me, example, I'm not always as motivated as I can be, and so I work out with my cousin, and that social aspect that I am able to bring into it enables me to be in a regimen that helps me. So finding things that will motivate you is important. So we've talked a little bit about alternative pain strategies, and again, there isn't a lot of data to support many of these. Cognitive behavioral therapy, there has been some research done, so cognitive behavioral therapy influences how you interpret and cope with pain, and it's more psychologically based, and there's some data in MS and in spinal cord injury, but it's mixed. Like we talked about with many of these alternative therapies, a lot of the data is mixed. And as I've said, it doesn't matter if it's mixed if it works for you. Same thing with acupuncture, biofeedback, and nerve stimulation. Has anyone tried TENS? transcutaneous electrical nerve stimulation. What was your experience with it? I'd like to hear. Sorry? Didn't help at all. Helped some. So again, you have it on right now, so I'm going to guess that means it's doing something probably. So that's exactly the point, though. So you see the variance in responses. Some people it didn't help, some people it was really a home run. And it's another thing that in other spinal cord conditions, there's very mixed data, just like we see in this room. There's another approach we're trying actually at Hopkins called scrambler therapy, which is a type of TENS, but it's supposed to, it has a scrambled waveform. It's similar in that you get the electrical current through the skin, but it varies the waveform, and it hits certain nerve fibers that are more associated with chronic pain instead of acute pain. And so the point really of me telling you about this is that there are things that are available. It's just a matter of people having the interest in researching these things, and really incorporating them with things that are already known to help is probably the best advice I can give you. Remember to pace yourself. So this means that you, rather than your pain, are in charge of how you plan, how you take breaks, how you interact with the world. And so when you pace yourself, you can accomplish something every day. So often people tend to, I'm having a good day, so I'm going to do as much as I can, and then they're burnt out for the next 4 days. And that's not really the most effective way to do it. I can tell from the laughing that everyone in this room knows what I'm talking about. It's better to break up tasks into smaller pieces, just do as much as you can with frequent breaks, work slower rather than intensely, and then change up your activities so that you're not overworking any one muscle group or any one joint or anything, so that you kind of have a lot of variety and can get some things accomplished every day. Another one of these vicious circles, I said there'd be plenty of them. So when you have pain, it increases your stress, which increases your physiologic tension, which increases your pain. And so another vicious circle, there's actually, again, mixed data to suggest things like meditation help. And, it's kind of become a new hot thing right now to do meditation, but even other things that incorporate activity like yoga and Tai Chi tend to have some ability to relax both your mind and your body while still exercising. And here's the ultimate vicious cycle. When you have pain, you tend to sleep not as well. When you don't sleep well, it affects poorly every aspect of your life. Your cognition is not as sharp, your mood isn't as good, you tend not to want to exercise as much, all those kinds of things. And so sleep is one of those things we really try to tackle in our clinic. So a lot of people complain of fatigue, and we talked about this. If anyone was in the NMO session next door, you're going to hear me repeating myself. But when you're not sleeping, we know that people who've had dysfunction of their spinal cord, it can be from lots of different reasons. It can be because you're waking up to go to the bathroom. It can be because you're having pain. There are lots of components to sleeplessness. And so really figuring out what is causing you to not sleep, fixing that problem is even better than just giving you a pill to make you go to sleep and then something to enhance your energy as soon as you wake up. So really figuring out what the root of the problem is in relation to your spinal cord dysfunction is what we try to do. And when patients report that they're able to sleep well over an extended period of time, not over weeks, but over months, they really report that they have enhanced energy, enhanced thinking ability. It affects every aspect of your life. And then stay engaged. So exploring, a lot of times when people have experienced TM and they're not moving the way they once did, they tend to isolate themselves. They tend to not engage themselves in activities that they once really enjoyed, either because they feel like they can't keep up and that they're going to be kind of slowing the group down if it's social activities, or because they just are independently having mood issues that are affecting their ability to participate. And the problem is that I don't have a cycle there, but it is a cycle. So then if that's the case, then you tend to withdraw more because your mood becomes more dampened. And so it's another one of these vicious cycles between doing things interactive so as to enhance your mood, so that you're not then in turn doing things less interactive. Not the best well said thing I've ever said, but you got the point, I think. So it's really figuring out new ways to do activities that you once enjoyed. So you might have to modify things, but still getting out there and not just sitting at home. And to that point, we heard from Dr. Banwell earlier the benefits of vitamin D. Many of us know it. Some of us are on it. Not as many in the room as ought to have been raising their hands for that question. But the point is that when you go out into the sun, independent of whatever effects vitamin D has on your immune system, just being in the sun helps you to enhance your mood. And so that's an important thing to remember, just going outside every day and enjoying a little sunlight on your face. And then figuring out other ways that you can help people. So it turns out that improved mood through helping others helps not only with your mood, but in turn helps with your pain. And then being connected to groups like this, all of you are in this room, so you are connected to groups like this. But even just not once a year or once every 2 years, but making sure you stay connected with people who really can impact your ability to feel social and meaningful, and that you're being productive in our world. And so I think I have a questions thing, but I know that that's not, this isn't the time for that, I believe. So I think that would be it.